Hello, everybody. Welcome to Thursday VMR. Today, I have the great pleasure of co-discussing with Youssef. And before we get underway, I'll just have Youssef unmute and just say hello to everyone. How are you, Youssef?
Yeah, hi everyone. I'm good. I'm good. I had like a soccer injury, so I had like an ACL repair surgery yesterday. So today is post-op day one, recovering, but excited to like learn everything. Ravi was just telling me how it was snowing, and he has a hill in his backyard. So whenever he's not discussing with us, he's going down the hill, tumbling in the snow with his dog.
Yeah, it's a lot of fun. I recommend that. What I should do is just stick to tubing. When you sit in that little tube and just go down the hill. Snowboarding can be dangerous.
That's
Uh,
every child's dream.
Yeah, but Yusuf, soccer. Oh gosh, I've been playing. So we have a team here. We compete against all the programs, and
Yeah.
I've been doing that since 2017, where we won the cup. So we beat all the residency programs. Now I'm like
Wow.
rethinking, should I continue to play?
Just take it easy. Take it easy, you know?
Right, right.
Yeah.
And today we have helping us. So Sana is going to be presenting a case. Do you want to mute and say hello and what have you been up to?
Hi everyone, I'm Sana from India. Excited to learn from the case and from Dr. Ravi and Yusuf.
Yeah.
Awesome. And go ahead.
Shreya, do you want to introduce yourself as well?
Yeah, hi everyone. I'm Shreya. I'm doing teaching points today and I'm hoping to have some fun learning with everyone.
Awesome. Et tu, David? Oh, David
Oh,
may not be able to unmute. Okay.
oh, there he
Okay.
Hi,
is.
friends.
How are you, David?
Yeah, I'm just great. I'm happy to be here. I've been a little bit missing in the last week. Um, Hi, friends. Hi, friends. Can you hear me? Yeah, I don't know if you can hear
Yeah, we
me.
can hear you
Just
now. It
I'm
cut out.
describing.
Yeah, it cut out a
Happy to
little
be
bit.
here and happy to attend Asana's case. And yeah, I've been missing for a few days last week because I'm maybe with hospital, but yeah.
Wonderful. Yeah, thank you, everybody. Thank you, Shreya and David, for helping us with this, and Sana for bringing a case. Sana, you want to present the first aliquot, and Yusuf, you take first dibs at it.
All right, so we have a 76-year-old male who is a farmer by occupation presenting with progressive fatigue, night sweats, and generalized weakness. That's it for aliquot 1.
All right. I think we lost the screen, but I'll just go ahead and discuss. So we hear about a patient who is a farmer, and here in the US, there's a stereotype that if you are a farmer, you don't present to healthcare unless you're like really, really sick. And like a farmer presenting to the hospital is like in itself is a red flag. But we also hear about other red flag symptoms. So we hear about fever, fatigue, and generalized weakness. And whenever I think about fatigue, it's usually non localizing particularly, but I always wonder if this is something going to be something we're going to find out on the CBC or the general chemistry. So is it going to be like a general screening? Are we going to find a low hemoglobin? Are we going to find an abnormal kidney function that's going to immediately lead us to an etiology? Uh, or is it something that's going to be like going to be found on like imaging, like a subacute malignancy that's presenting. And we hear about fever. And usually, when I think of fever, you want to divide it into acute fever versus subacute to chronic. And the more acute it is, the more likely it is infectious. And the more subacute to chronic it is, the more you want to consider all the factors under the IMAID mnemonic. And I think that's as far as I'll take it. And then generalized weakness is asthenia, not putting a lot of cognitive effort into that until we hear more. Anything you would add, Ravi?
No, just to add to what you mentioned here, I just love you sort of work through the complaints to get to maybe what is the most interesting thing here, which is the fever, and then looking at the age and then the profession. So what I was envisioning, while you were talking and going through what could be the problem, malignancy is a great thing as well because yeah, farmers, yeah, they're busy working. They're sons of the soil, right? They toil, they grow food, they provide us with much necessary crops, vegetables, and so on. So they do a lot for us, and they work hard. And I think about what do farmers, who are they, and what are they in contact with? So they toil with soil, right? And what do we find in soil? So we have a marvelous abundance of different mycoses, endemic mycoses. I've had cases of farmers with infections from the soil as well. So that would be one thing. If we're thinking about fever, could there be an infection from somewhere where they work? The other thing is, who do they encounter? Animals, right? So just sort of looking back at a case I presented, it was a very fun case. I had a farmer that was had rabbits, dogs, cats, sheep, cows, everything. And so in my mind, I was going through all the different organisms that he potentially could have been affected with, and it was Bartonella at the end of the day from the cat. And he was drinking unpasteurized milk and so on. So Brucella, we were thinking all those wonderful things. So the animals, the soil, and then they're out in the sun. It depends. They're in India. So what do you get from the sun? Malignancies. We haven't heard of anything on the skin, so I would worry about that as well. Those are a few things that come to mind. We're still kind of early, but yeah, fever is really going to help us to expedite the diagnosis. But then I also want to look around where the farmer is to see if there's any clues as to what may be going on. Any other thoughts, Youssef?
No other thoughts. I think it'll just be, I'm curious to see if it's an actual fever, if this was measured, and if we have any pattern to it or not. So, Sana, I can't wait to hear more.
All right, so he has a past medical history of hypertension, hyperlipidemia, hypothyroidism, osteoarthritis, and rosacea. 3 months before presentation, he began noticing worsening of his baseline arthralgias involving the hands, shoulders, and knees, accompanied by stiffness and a progressive decline in stamina. So the way he described it was he was unable to work continuously, and he had to stop roughly half an hour after initiation of work because he felt like he was hitting a wall. During this interval, he also developed drenching night sweats, all of which he attributed to his age.
Okay, we have a bit more background on what's going on with this patient. If we kind of move away from the fever and these drenching night sweats, what's interesting, we have hand and joint involvement, and it appears very symmetrical, right? So shoulders and knees. So we have a symmetrical bony involvement, and this particular sort of involvement is of the joints. So these are arthralgias. Are they indicative of actual bony destruction of the joints, or are they just inflammation causing just pain in the joints? So when you have any sort of infection, a viral infection, flu, you tend to get some arthralgia, which is just non-specific pain within the joints. But when you actually have bony involvement with inflammation, you get destruction maybe in certain ways. So you get sclerosis, you get endochondral cysts and other change of architecture. The cartilage may also begin to disintegrate. And so here we have to figure out if we are dealing with actually arthritis versus just non-specific arthralgias. So is this inflammatory or non-inflammatory? So one of the most common causes we see in somebody of this age, especially somebody who's working hard, is probably going to be osteoarthritis, and that's usually specified by the time, the degree or the time of the stiffness that they have. And Sana had mentioned morning stiffness. So if it's usually the hard and fast rule is less than 30 minutes, it's going to be non-inflammatory, something like osteoarthritis, so things that you can look at, time less than 30 minutes of the pain with the osteoarthritis. Sometimes they also have this gelling phenomena, which is like it feels like your joints are very gooey and very stiff, and you also work through that within 30 minutes. But if you have inflammation, a pain that's beyond 30 minutes to 60 minutes, you're then dealing with maybe an inflammatory condition. And what kind of like arthritis, symmetrical joint involvement conditions that you have? You have rheumatoid, you have lupus. Here, I don't think it's one of these. Although the age range at this, I guess epidemiologically, this age range, you can get in males lupus at this age, but all of a sudden developing lupus is very odd. So I'm thinking maybe this is osteoarthritis. But then we also have to think about this fever, and I'll leave the night sweats to Youssef.
Yeah, wonderful, Ravi. And like you're saying, I'm diving in, going further into the IMAID mnemonic, so infection, malignancy, autoimmune, drug, endocrine. I think the big three we're thinking of are autoimmune, infection, and malignant. Under autoimmune, Ravi already mentioned, could this be like seropositive, like lupus, RA? And then I'm also wondering about like seronegative diseases. So could this be like ILD related? I'm looking at what company, if it is autoimmune, what company is it keeping? So if I'm doing the exam, I will listen for crackles, look for any lung symptoms to see if there's any ILD, if there's any cutaneous findings, if it's lupus, so I'll look at the skin very thoroughly. And then under malignancy, generally on exam, you're just going to palpate for like lymphadenopathy to screen for lymphadenopathy. Then in terms of infections, you just really want to like do a very thorough exam. So endemic mycoses, some of them, like blastomycosis, up to 80% of cases present with a rash, for example. And then even other infections that are like chronic. It's very interesting to separate infections into acute versus chronic, because acute infections you think of like common bacterial causes. So you think of like staph, your strep, your E. coli. But then the more you go into the chronic phase, you consider indolent infections. And under indolent infections, we think of things like tuberculosis, endemic mycoses, and then the infections that live in the blood, like Ravi mentioned, like Brucella, Bartonella, Coxiella. So if we hear any exposure to any cattle or pasteurized milk, etc., we can consider those, because those are also like subacute to chronic. So it's a whole different category. And I think the next thing I'm looking for is like a very thorough exam. And Ravi, do you think it's going to be infectious, malignant, or autoimmune?
Oh, Yusuf, wonderful breakdown. Yeah, of all the possible infections. Yeah, I think this has kind of an infectious flavor if you think about it. Maybe the joint issue is probably just synovitis, probably nothing more. But yeah, infection is interesting. Yeah, especially with the night sweats. No weight loss, right? I don't see weight loss is non-specific as well. It can happen with inflammation. Does the age influence? What do you think, Yusuf? The age influence you? I mean, at this age, which
Yeah.
one would you prioritize?
Yeah. I think the older you are, like I think the malignancy goes higher than autoimmune in my mind at least, and I think infection remains the same. So infection risk probably the same, malignancy goes up, and autoimmune goes down in my mind.
Wonderful job. Back to you, Sana.
We have some more history before we get to the exam. So over the past few weeks, he noticed tender lesions on several fingertips after cold outdoor work. He described them as small, painful, violaceous bumps that sometimes burned or itched. 4 weeks before presentation, he developed acute onset of fevers, sore throat, upper respiratory symptoms, diarrhea, and myalgia. He was evaluated and diagnosed with influenza B. And although his fevers and sore throat and URI symptoms resolved, myalgia, cough, and diarrhea did not fully remit. In the weeks after that, he developed swelling over the feet and ankles symmetrically, which he attributed to drinking more water to avoid dehydration given his recent influenza illness. He denied fevers, besides this, rigors, or unintentional weight loss. For the meds, he is on lisinopril, levothyroxine, and rosuvastatin. Family history: his sister had vitiligo and celiac disease. His brother was diagnosed and treated for TB. He drinks about 30 to 40 units of alcohol weekly and has been doing so for the past 50 years. Has been monogamous with his wife for the past 41 years. And 50 years ago, he was diagnosed and treated for chlamydia. There's no significant allergies. And that's the third aliquot.
Wow, what an aliquot, Sana. So it sounds like what initially sounded like possibly inflammatory is now definitely inflammatory. And this syndrome seems like very, very active. And we were waiting to see if there would be like a dermatologic component, and there was. And we hear about like violaceous papules that or lesions that popped up. It's really, really interesting, and also developed like swelling of the both feet. So I'm wondering about these violaceous papules. What is the differential for that? So is this like a primary cutaneous disease, like Ravi was mentioning earlier as like a malignancy, but usually it would not be like so diffuse and would not be so hyperinflammatory. So I'm wondering about things like could this be like erythema nodosum that was like developed intermittently? And we were mentioning like endemic mycoses that can present very commonly with rashes, like histoplasmosis presents with erythema nodosum commonly. Endocarditis initially crossed my mind, like subacute to chronic endocarditis, but we don't hear about like any lesions on we hear about the fingers earlier, but maybe not the feet. So I'm still in the back of my mind. And then one thing that crossed my mind was pharyngitis or the sore throat. And is pharyngitis going to be part of the final syndrome? Really hard to say, but pharyngitis has a very narrow differential. And whenever you see anybody who presents with pharyngitis, even though they're diagnosed with the flu, it's very specific. It also has like other infection. You consider viral etiologies like they did, but also this can be caused by histoplasmosis, endemic mycoses. The malignancies that cause pharyngitis include leukemia and lymphoma. And the other immune syndromes that cause pharyngitis include lupus and Still's disease. So Still's disease commonly presents with pharyngitis and like intermittent fevers and rashes. This is where my mind is at. I think this aliquot broadened my differential instead of narrowing it. What would I want to do next? I think exam, see if I can like the rash is still there. And then a basic set of labs, but and then I'll take it from there. Ravi, where's your mind at?
Great job there, Youssef. I think, yeah, I agree with you. I'm right along there with you in this journey that we kind of moved into the space of inflammation. What do we have here? We have fever, which is a response to either infection or inflammation, but there's a lot of signal for inflammation, the arthralgias. We have skin lesions. We have mucosal association, right? So the mucosa is inflamed, and any disruption to mucosa, you can get hypersecretion, hence the diarrhea. You can have a sore throat with infiltration into the mucosa. So yeah, I think if you try and link all these different components, you may get an idea of inflammation, but infection, we have to still be cautious because infections can manifest in this manner as well. What's kind of interesting is I'm trying to piece together with the swelling of the feet as well. What does that have to do with it? We have a reason given to us, and we have to be very careful because this can then introduce bias, right? So the patient says, I've been drinking a lot more water, that's why my feet are swollen. We will tend to then discard this or put this aside. But I would be careful because I've been in situations where patients have told me a reason why they're having this condition, only to then later find that it is not that condition they were that reason, but something else that was important to recognize earlier on. You know what's interesting in this family history, looking at this, the brother has TB. So TB usually, you'll see this patient is from India. So TB is one, I think Lucas was mentioning. Yeah, this TB you always have to think about. And TB is one of those great mimickers, right? There's certain conditions that are great mimickers: sarcoidosis, lupus, lymphoma, TB. We have to think about these conditions, right? Then the sister with vitiligo and celiac disease. So it looks like within this family, there are certain conditions that could be transmitted. So is there immune complex or immune immune-associated condition that is in this family. I kind of have difficulty trying to recall if there is an association. But at this point, I'm trying to link all these different areas. And I think I agree with you, an exam will be helpful. Rushing to a diagnosis, system one thinking, these violaceous tendon nodules, I couldn't help but think of dermatomyositis. But we don't get any signal here for muscle association, right? But violaceous tendon nodules will be something along that. Sarcoidosis could be something like that. And also, being a farmer, you're working with your hands. So I'm also wondering, could this be something from work, like the soil? I love your thought about endemic mycoses. Could this be a manifestation of endemic mycoses? We'll have to keep that also in the back of our minds as we go through this case. Back to you, Sana.
So on examination, he was afebrile, hypertensive with a BP of 140/66, with a normal heart rate, and the respiratory rate and oxygen saturations were normal. Cardiopulmonary exam and abdominal exam were unremarkable. No tenderness or abnormalities to palpation of temporal arteries. Mucous membranes were moist. Oral examination did not reveal any abnormalities. There was no goiter. Mild axillary lymphadenopathy was present bilaterally. On examination of his hands, there were small, painful, violaceous bumps at the tips of his second to fourth fingers of both hands. There was also purplish discoloration at the ends of all 10 fingers with a clear horizontal cutoff. The nail fold capillaroscopy revealed dilated nail fold capillaries. Musculoskeletal examination revealed synovitis of the wrists in both hands, bilateral Heberdens and Bouchard's nodes. He had pain on palpation of ankles and knees and slightly restricted range of motion of both shoulders, but the exam was limited by pain. There was also a faint rash without telangiectasia or papules.
Thank you, Sana. And do you think, Sana, this is a good time to create breakout rooms, or do you think we wait one more aliquot?
We have some more history for the next aliquot, but I think it'll give some
Okay,
diagnostic clues
okay,
away. So let's do it now.
okay. Ravi, I'm going to create some breakout rooms quickly. Welcome back, everyone. If anybody has any thoughts, feel free to put them in the chat. Love to hear from you. Lyra, thank you for scribing and jumping in. Ravi, loved hearing your thoughts about the violaceous papules and the nail capillaroscopy. Do you want to share them out loud?
Oh yeah, we ended up in a room with Lyra, David, and Youssef, and we're kind of thinking about how to relate all these findings. I think the exam is great here. It just tells you when you're looking for hallmarks of maybe a inflammatory disease here. When Sana had mentioned violaceous papules on the hands, we tend to think about autoimmune conditions like dermatomyositis. So here we have probably Gottron's papules, and we would look for skin changes elsewhere. And the nail fold signs, usually I see that with systemic sclerosis, right? We were thinking about it. But what it indicates is microvascular injury. So there's injury within the capillaries of the nail folds, and those can be seen in certain conditions. Systemic sclerosis, you will get this. And you could also actually get this in dermatomyositis as well. There is sort of this bushy configuration which could be seen. So I'm not an expert at that. I'm usually with dermatomyositis, if I see a case or presentation, usually it is with the skin changes and the muscle association. But the nail fold is interesting. Yeah, I mean, you could get overlap syndrome, mixed connective tissue disease, but here, I think Youssef, you had a great sort of way. You wanted to break this down with testing, right? We have certain
Yeah.
hypotheses, but testing. You want to maybe elaborate on that?
Yeah, I think this patient were worried about dermatomyositis initially, and whenever you're worried about dermatomyositis, it's not like a mild disease. It's really very concerning. We have a syndrome that's showing us on the skin what are the findings there, but you also wonder, is there any like destruction on the inside of the body? The biggest one you want to think about is like ILD. So if you have like MDA5 dermatomyositis, that's a very rapidly progressive syndrome that actually can cause HLH and can cause like rapid deterioration and even death if not treated very quickly with mega doses of steroids and more immunosuppression. So early on, you like let's say in this case, you immediately want to get like CT chest to look at the lungs. You want to get a CK to see if there is like a component of muscle destruction, and if there's like rapid muscle destruction, you quickly want to consider immunosuppression. And then in anticipation of immunosuppression, you want to start sending immune workup. So what immune workup would you send in this case? So you would send blood cultures, you would send an HIV screen, and then you would send a quantiferon gold. If you remember, like a lot of these immunosuppressives would reactivate TB if you're at risk. So you want to screen for latent TB. You also want to screen for hepatitis B. So if you've been exposed to hepatitis B, even if you're immune, a lot of times if you're getting significant immunosuppression, you start actually treatment for hepatitis B concomitantly with the immunosuppression. So that's something you want to start very early on. And then we were wondering if could this be like an overlap syndrome, like a mixed connective tissue disease or an ILD syndrome. And we're gonna get this workup very early on and get our consultants very early on. And maybe urine histo, like why not? I think I would screen for that, especially if we see something on the lung. But not with this like skin findings. I'm moving very quickly towards imaging, CK labs, and preparing this patient to be immune compromised at some point. I see in the chat somebody says HIV, syphilis, for sure. Okay, Sana, I can't wait to hear more.
We have some more history. For the past 20 years, he described several cutaneous lesions that occurred intermittently on his cheeks. The rash tended to worsen in sunlight and with heat, but was not painful or pruritic. He saw a dermatologist and was diagnosed with rosacea and prescribed a metronidazole ointment and was advised to use photoprotective apparel. Over the past 4 years, he reported that his skin bruised easily and that this would sometimes occur when going into the sun. And approximately 10 years ago, he was in a farming accident where a horse fell on top of him and he had suffered a hip and ankle fracture, for which he underwent a hip replacement surgery and mechanical rod placement in his ankle approximately 8 years ago. Do you want the labs now, or should we do that in the next aliquot? Okay. So his CBC, CMP, TSH, HbA1c, all of those were normal. His CK was 426, which is high. Ferritin was 528, also high. Uric acid was 6.7, high again. LDH, ESR, CRP, HIV, quantiferon gold, hepatitis B, hepatitis C, blood cultures, parvovirus B19, vitamin D levels, vitamin B12, folate, all of these were normal. His ANA was positive to a titer of 1:320. His ANCA was negative. Rheumatoid factor CCP was also negative. On urine analysis, there was 1 plus protein, 1 plus blood with a few RBCs. SPEP and UPEP were also negative.
Very, very well presented, Sana. You delivering each aliquot just perfectly. A very interesting case as well. Thank you for bringing this, because it's triggering all sorts of thoughts here. I'm going to take the elaboration of the history of Youssef, which is interesting that there's more skin involvement. So what do we have here? We have a signal of fever. We have cutaneous association. We have capillary association. We have lymph nodes. We have mucosa involvement. And again, you try and think about what kind of mechanisms could involve all these different areas. And still, I think autoimmune conditions probably is a cause. Any malignancies? I mean, you can get cutaneous malignancies, but it wouldn't manifest. I mean, I guess leukemia cutis could, but not this diffuse and causing violaceous pupils. There's only a few kind of skin lesions that would be violaceous. There's Gottron's papules or patches would be that, lupus pernio and pyoderma gangrenosum. And there's one or two more if I remember. Maybe yeah, it's escaping me. Here, though, now we have rash on the cheeks here as well. So with the skin involvement with dermatomyositis, heliotrope rash, the cheeks, you get exposure. I don't know though if it's associated with sunlight, if it gets worse. We do have the hands as well. We are missing the shawl sign. We're missing the gun holster sign as well. We do have the telangiectasias under the nail or the capillaritis under the nails as well. And then this is interesting. Skin bruises easily. To me, that means a couple of things, that the vessels are fragile. Could this be vasculitis? Or could this be an overlap with dermatomyositis and in the vessels itself? We already have the signal within the nails. So could this telangiectasia be causing this bruising, or fragility causing this bruising? I doubt if we do coags. I think we also need to do coags to make sure it's not due to hypocoagulable disorder. And there's traumatic hip and ankle fracture. Now we have bones sort of thrown into the mix here. So I'm gonna we'll have to process that, but I'll let you go over the labs and see if we make any progress.
Yeah, absolutely. And I think when I think of myositis, so I think of like dermatomyositis, I think of also like antisynthetase syndrome, which is myositis, ILD, polyarthritis, and mechanics hands. And we see features of it here. We see like, could this photosensitivity be like the heliotrope rash? And we see the elevated CK here. But of note, we also see findings that are consistent with other autoimmune diseases. So, for example, we see 1+ protein and 1+ blood. So, whenever you see RBCs on the urine and you see protein, that's almost never normal. You want to explain it. So, whenever you see protein, you want to think, is this patient diabetic? That's the most common cause of proteinuria worldwide. We don't hear about a history of diabetes. So, but we see also like blood, and usually if there's blood but no RBCs, you think of just myoglobin. But here we have blood and RBCs. So could there be a component of early glomerulonephritis, even though the kidney function is normal? Could there be like early damage? So that makes me think of lupus. And whenever I hear of like, we hear features of lupus, maybe like photosensitivity, maybe a rash on the face, plus other immune disease, I'm starting to think about mixed connective tissue disease. We're seeing like overlap of multiple syndromes. We don't see like, if you want to diagnose lupus, you need to open the ACR criteria, and then you try to map the ACR criteria with your patient. You need like at least 5, which includes things like hemolytic anemia, the classic rash, nephrotic disease, etc. But here, it doesn't fit like one disorder. You're thinking about more than one. So I'm really thinking, could this be mixed connective tissue disease? I think complements would be helpful. Lung imaging would be helpful. How would I take this case further? I think I would send a myositis panel early on. I think if we get like a positive antibody, that would be early confirmation, and that would be helpful. And ANA always has to be taken in context. Is this an ANA? What is the context of this ANA? And here it's the context of having some photosensitivity, possible early GN. So I'm trying to see, is this like an overlap syndrome, which I'm most worried about? And then the ferritin just confirms that the patient is very inflamed. What would you do next, Ravi?
I would send for the autoimmune testing. So definitely get some more. Do we have the anti-Smith, anti-double-stranded? I don't see. And then the antibody for mixed connective tissue disease, and see if they can shed some light. Do we get complements? No, I don't see complements there. So I'd get those two. And what's interesting about ANA, ANA can be so non-specific. It is elevated. I think usually the textbook for the resident textbook makes up, will say 1 to 80 is significant, or I've heard 1 to 80 on curbsiders. We should consider that. But 1 to 160, actually, Jeffrey said this morning, 1 to 160. And then I heard another rheumatologist say 1 to 320. I don't even wake up for 1 to 160. So 1 to 320 would get their suspicion. The degree of elevation of ANA doesn't correlate to the likelihood of, say, lupus or other conditions. And if we think about ANA, what conditions will it be elevated in? So one would be mixed connective tissue disease. The three S's, so lupus, SLE, scleroderma, and then Sjogren's. And then the last one would be myositis, I think idiopathic myositis. So those would be the five conditions to think about. So MCTD definitely is in the running, as we have a lot of, and I think the lymphadenopathy is pretty strong with that. So we have a sprinkling of different conditions which could make up mixed connective tissue disease.
Yeah, yeah. And I don't know if I'm saying this because he's a farmer, but we've had cases in the past of Coxiella or Bartonella or Brucella presenting with glomerulonephritis and a positive ANA. It's one of those causes that causes a false positive ANA. So I think this patient at least has some dermatomyositis, or at least a myositis component. Could he also have an infection that's causing all of this, like ANA and the GN? Possible. I think I would want to hear about like the animal exposure if he has any. We hear about the horse that fell on him. So I want to see if there's any other animals that he's been exposed to, or if any other animal fell on him, and then that might like explain the other fevers as well, or why it's flaring right now. Keeping that in the back of my mind. I don't know if I would have sent that workup without the exposure, but I think given the exposure, it's hard to discount it. And there have been cases where on VMR where the patient even presented with GN, positive ANA, even started on steroids. And then later on, they found that it was actually Coxiella, for example, or Q fever. So really interesting cases, but I'm always going to keep that in my back of my mind whenever I hear about like a farmer. And I'll share that VMR in the chat shortly. It's Mark presented the case in Utara.
So after this, a TTE was performed due to the complaint of lower extremity swelling and fatigue, which showed normal cardiac structure and function. Radiographs of the hands and wrists showed multiple osteophytes, subchondral sclerosis, and narrowing of carpometacarpal, distal interphalangeal and proximal interphalangeal joints. Radiographs of the knee showed moderate tricompartmental narrowing, and pelvis and sacroiliac joints were unremarkable bilaterally. Chest X-ray was also normal. CT chest showed a solitary pulmonary nodule of 4 mm in the right middle lobe that was unchanged from a previous scan 4 years ago, and a small pericardial effusion. We have some more labs. Do you want to get those now? Yeah, okay. So a USDR was done, which revealed 2.4 grams of proteinuria. Extractable nuclear antigen panel was sent, which was normal except for isolated elevated anti-dsDNA, which was 1:320. Infectious serologies for zoonotic infections like Bartonella, Coxiella, Brucella, Francisella were negative. Tick-borne infection serologies, including Anaplasma, Lyme disease, and I have a tough time pronouncing this. I'll just spell it out. EHRLICHIA. Yeah, it was all negative.
Wow.
Yeah, that's
Thank you,
for the
Sana.
salad water.
Thank you. And as Dr. House always says, it's always lupus. But jokes aside, the best way to diagnose lupus is to like open the UACR criteria, which is the American College of Rheumatology criteria, and up to 1 in 4 patients with lupus have pericarditis or pericardial disease. So it's really common. So he picks up like 1 point for that, and we hear about the ANA and the dsDNA. ANA is not specific, but the dsDNA is specific. So that's the second one. And then you hear about the signs of glomerulonephritis. So how do I know this is glomerulonephritis? Whenever you see protein and RBCs, this combination should make you think of GN, unless you have like something else causing both independently, like diabetes and UTI, for example. But here we hear about that the patient has protein, blood, RBCs, and proteinuria. Proteinuria, again, never normal. And this is 2.4 grams, which is pretty significant. So this patient probably has lupus nephritis, if I had a guess. And then the lupus nephritis class will determine your treatment. So a lot of times in these patients, you end up doing like a kidney biopsy and then you try to see the class there, or in this case, you might start like empiric treatments for it. Ravi, what am I missing?
Yeah, I like that thought there. You know, you won't. We were looking for certain signals or pattern recognition for lupus. We are epidemiologically in this age range. Remember, there's two age ranges where you can have lupus rear its head. So one would be 50, 60 and above. Mostly men more than women, and then the early onset, which would be in the 20s, 19, 20, more female than male. Here we're not seeing like the laboratory pattern complements normal, no cytopenias. But is this a flare? When you have a flare of lupus, you do tend to get these changes. So the patient's coming with a whole host or multitude of complaints, night sweats, fatigue, weakness going on. So if this was lupus, is this an acute flare? Not sure. I mean, we didn't so far get the RNP antibody at this moment. I don't remember in the ENA if RNP is in there, but I would definitely be interested because there's a lot of overlap. And the GN, I agree with you, it definitely is there. But yeah, definitely more testing. Occasionally, when we don't know what's going on, would they go for a biopsy of the lymph node or maybe the kidney? Yeah, I've seen where it's very kind of sketchy, the diagnosis, and maybe you need to get actual tissue if the markers aren't really helping you in this journey. Anything else, Youssef?
No, I think you're right. Like the U complementemia is like surprising, having like normal complements plus a GN. And in those scenarios, you think of like ANCA-associated vasculitis, which can present this way. But we don't see any other like lung findings or like sinus node findings. You think of like IgA nephritis or anti-GBM disease, but again, no lung disease. So I wonder if it's like I'm still in the like lupus, mixed connective tissue uh, disease space. And I like what Jeffrey taught me is that an ANA only buys you like a screening test. It doesn't necessarily like give you the diagnosis, but like it's like the security guard at the door, and if the ANA is positive, you're allowed to be screened further. But it only gets you in, but doesn't necessarily give you a diagnosis. So I'll be thinking about that, and I'll be speaking to like nephrology and rheumatology at this point to see what to do next.
Yeah, the only other thing, the last thing I'm going to say is like with the lymph nodes and all of this, either we are in the correct space or do we need to look at other cells causing disruptions within the body and attacking these tissues? So certain histiocytosis, do we need to look at the lymph node? Lymphoma still is at play, and lymphoma can have definitely paraneoplastic syndromes. And is there these multisystemic conditions? I doubt this is a paraproteinemia associated condition. Hip and ankle fracture, we don't have the anemia. So at this juncture, we have kidney associated issues. So that's something to think about. And we haven't done necessary testing. Just a few things to think about.
Yeah, I think lymphoma is a great idea because a lot of times it can present with like AITL specifically can present with like inflammatory symptoms, and a GN. It's really hard to rule out early on. I think it'll be like you will never know if it's like truly ruled out until you like have the test of treatment and seeing if all the lymph nodes go away as well. And maybe an LDH will see. The CT chest did not show any lymphadenopathy, which is good. And you'll probably look at the abdomen, see if there's any lymphadenopathy, check an LDH, and after that, just be really careful, I think.
All right, so at this point, if you had to get one last test to confirm the diagnosis, what would you do?
Ooh, I think we wanted, we already got the U1 RMP that was negative. Uh, yeah, I think there was like a famous criminal who said, I go to the bank because that's where the money is. In this case,
Yeah, that's
I go to
really Sun's law,
yeah,
right?
Sun's law.
Go where the
Yeah,
money is, the bag.
yeah. So I wonder if going to where the tissue is, which is the kidneys. What about you, Ravi?
Yeah, I think so. I think it's just a lot of noise, and I think let's see, whatever is attacking all these tissues, it is predominantly in the lymph node. The bone marrow, I don't think is involved. The lymph node needs to be evaluated. Let's go there. I may be wrong, but we'll take a chance.
Yeah, so this was originally Dr. Jeffrey's case. I did not share this because I did not want to give the diagnosis away. So a renal biopsy was performed, which confirmed lupus nephritis class 3.
I forgot. Yeah, the kidney was the other one we were talking about. So amazing case, Sada. Yeah, that's amazing. So yeah, right, Yusuf. Sometimes like where's the case? I presented a case of antiphospholipid syndrome, and there wasn't a lot of signal for lupus. There was some kidney failure. You do a kidney biopsy, and you get the diagnosis from the morphology of the biopsy. So great. It looks like a very invasive measure to get the diagnosis, but you do need to go there. Wonderful case. Amazing, amazing
Yeah, I love
delivery.
it. I love it. Yeah, and lupus is like again like very elusive. A lot of times you start picking up the ACR criteria one by one, and then until you have like the treatment threshold is reached for you to start treatment. And a lot of times you involve nephrology or rheumatology, but nephrology actually decides on the treatment based on the pathology. So they will biopsy, and depending on the class of the biopsy and the degree of proteinuria, it determines the degree of treatment, which it can include like steroids, cyclophosphamide sometimes, and even hydroxychloroquine as well. So that's always very helpful to do that. I'm surprised the complements were normal. I think that was the one that caught me off guard. That was the one that was making me doubt the diagnosis. And a lot of times, if lupus in men comes flares with a stronger veracity than in women as well, it can have present worse actually. Any reflections, Ravi?
Yeah, I think what's interesting that can really divert you, but think about it. This is, this is not one snapshot in time. This is a continuum. So next week you do the complement, it's going to be down. I think double-stranded is associated more with the kidney disease or with kidney involvement. I'm trying to remember, but you don't have to get all the markers. Remember, there was a case somebody presented where all the markers were negative, and we had to diagnose lupus through biopsy. So you may get like nothing. You were ANA normal, the complement normal, anti-double stranded, anti-Smith normal, but lupus is still kind of in that smoldering phase. And then next week the markers will be positive. But absolutely wonderful, wonderful job, Yusuf, like early considering lupus as a potential cause. And it can be very difficult to diagnose. And what I learned from Jeffrey also is when you have a patient like this, sometimes it's not like you give the label to the patient because again, this is a continuum. You're gonna maybe the manifestations will show up next week. The important thing is stabilize, get the labs and get them to the right person, which will be the rheumatologist, and then they will work on it.
Love it. Shri, I can't wait to hear the teaching points.
Awesome case and awesome discussion. Thank you for bringing this. So yeah, we had patient 96-year-old male coming with night sweats, fatigue, and generalized weakness. And the patient also had, patient had a lot of symptoms, but patient came in with fever. We should always figure out if the fever is acute or versus chronic or subacute or chronic. In acute fever, duration of fever, we always think of infections more, while subacute and chronic we think of autoimmune along with infection, malignancy as well. If the patient has generalized weakness, we need to keep literally everything in mind. It could be just because of anemia from blood issue, like anemia, or it could be infection, viral, fungal, bacterial, versus any chronic multisystemic syndrome can cause generalized weakness as well. So patient was a farmer. So when patient, as Dr. Ravi said, farmer toils in the soil, we should always think of causes from tuberculosis to endemic mycosis like histoplasmosis, blastomycosis, or patient could have cattle exposure. So we should also think of brucella and coxiella like infections in back of our mind as well. So patient also had arthralgia. So we should always figure out whether it is an arthralgia secondary to non-specific consequence of something like viral infection, or is it an arthritis? If it's an arthritis, again, we need to consider infection versus autoimmune as well. So patient also had morning joint stiffness. So if it's less than 30 minutes, we always think of osteoarthritis, while if it's longer than that, we think of other autoimmune pathology like rheumatoid arthritis. Patient also had violaceous nodules, which were sometimes itchy. So patient coming with arthralgia, fever, and violaceous rash, we should always think of autoimmune panel more, like dermatomyositis, scleroderma, even Still's disease, or endemic mycosis can present like this as well. So we on examination, we had dilated nail fold capillaries, which could be due to microvascular injury, and we should always think of autoimmune conditions like dermatomyositis, scleroderma as well. We also talked about MDA5 dermatomyositis, which can progress rapidly and lead to hyperinflammatory symptoms like HLH. And patient also had blood in urine with RBCs. So we should always think of early sign. It could be indicative of early signs of glomerulonephritis. And the first thing that comes in our mind is lupus. So this at this point, with so many symptoms and findings the patient had, we were thinking of the 3S like SLE, scleroderma, Sjogren, along with the myositis, but we couldn't figure out which one we should lean more on. So we were also thinking about maybe it's something like overlap syndrome. And finally, once again, tissue was the issue, and patient was diagnosed with SLE and confirmed with a renal biopsy. So it was really fascinating case, and it was wonderful discussion. Thank you for this.
Thank you so much for your excellent teaching points. Thank you everyone for joining. Look forward to tomorrow's VMR. I'll be discussing with AMK and encourage everyone to sign up to present cases. Hope you all have a wonderful day.